Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome back. Feeling like a star. You can't stop my shine. I'm loving cloud nine. My head's in the sky. That's right. I'm riding solo. That's for all those pop fans out there like Jason Derulo. All right, got another episode for you, which I think will be thought-provoking. Before I jump into the topic at hand, I want to say thanks to everyone for listening. For those hardcore listeners who've listened to many episodes, I don't have to say this out loud, but I will. You know by now that I'm an idiot, right? I'm just, like Joe Rogan always says, just the dude asking questions. I don't know too much. I just enjoy asking questions of smart people and learning some stuff. So hopefully you've learned along the way. I'm sorry for all my flaws. I don't have a great voice. I don't have a great cadence. I don't have tons of knowledge. But what I do have is sheer determination and grit to find some good guests for this podcast. And as you know, you cannot keep me down. I will keep pounding the pavement for you guys. And thank you to all of our wonderful guests who've been on the podcast over the years. They've shared so much knowledge and wisdom, things that have changed my life, things that have altered the careers of many listeners, and it warms my heart to hear the things people have learned, the connections people have made. Sometimes job opportunities have been found through our guests and podcasts and things that have been said. So thank you. It's a group effort to do all this. Okay, so today's topic is something that it means a lot to me, but it may not be so satisfying because it's more of a discussion and less of a big solution at the end. But I do think it's an important discussion to have. I'll start off by introducing it by saying, so I've been practicing since residency now. I've left residency over 13 years ago, and I've been doing oral surgery nearly every day ever since. And so I don't know, once you get past many years, you start kind of analyzing what the time doing oral surgery that long does to you. So here's a question for those who are close to finishing residency or those who have finished. I think a lot of us, once we end, we kind of step back and look at ourselves and think, man, I changed a lot during those 4 to 6 years, right? And how did I change? And what did that huge experience do for me as a person? Like, how did it change me? Sometimes even our own personalities are changed to some degree. The way we see people, the way we interact with people, the way we see ourselves is often changed through such a profoundly tough experience. But then you start doing longer periods of time, not just 4 years or 6 years, but what happens in 10 years, 15, 20, 30 years of doing oral maxillofacial surgery. There's many things that we're exposed to day in and day out. I think it's naive to think that those things don't change us in ways that sometimes and oftentimes we don't really realize because it's a very subtle change. I want to focus on basically what happens to us as surgeons when we are exposed to other people's suffering and pain through our jobs day in and day out. A couple quotes from people that I thought are interesting. One is by Jim Rohn, and he said, I think a lot of you have heard this, but the quote is, "You are the average of the 5 people you spend the most time with." And I know there's a lot of discussion. Like, you could say that's grossly oversimplified. that quote, but I think there's something there that you are very similar to, or at least you're very much affected by the people you spend the most time with. Rachel Hollis said, "You become who you surround yourself with. You become what you consume." I think a lot of us would agree. Your body becomes and changes according to the food you consume. I think same could be said for your mind and the things that you're consuming or experiencing um, mentally, physically on a daily basis affect who you are. Popular proverb is you become what you surround yourself with. Energies are contagious. Choose carefully. Your environment will become you. Whether we like it or not, part of our profession that we've all kind of agreed to deal with on a daily basis is the consumption or the kind of daily experience with suffering and pain of others. I think a lot of us do that um, in a way of wanting to help, and we think more of, yeah, we're doing something valiant and noble, which it is, but the other question, the other side of the coin is it helps our patients, but the other side of the coin is what does it do for us? Is it changing us in any way? So um I wanted to talk about that very important discussion. This is a topic that may feel a little uncomfortable at first because surgeons are trained to be steady, efficient, calm, and decisive. We're trained to solve problems, manage emergencies, and keep moving forward, but very few of us are ever taught what happens to ourselves when we witness pain, fear, trauma, complications, and suffering day after day for many years. I think this really is for any doctor slash surgeon who sees pain. I mean, you could say this for the general dentist as well. I think even just the fact that a dentist, a surgeon, periodontist, those who are giving injections daily, hourly in the mouth, yes, it's in the name of helping someone, but we're causing pain, right, and stress just through the injection. So if you multiply up all the times we gave someone an injection and the suffering, the pain that caused someone else, it's like, yes, it's in the name of trying to help someone, but it also is kind of to some degree, I guess you could say a little slightly subtly hurtful to your soul because you are causing pain to someone. That can have a very real psychological effect on people, let alone the great pain sometimes that we can inflict on someone through a surgery procedure, such as extraction of third molars, dental implants. Complications can cause tremendous suffering, infections, and then you can get into even bigger surgeries like treating cancer patients, orthognathic procedures, and just the amount of pain that we inflict. And usually we just kind of, brush under the rug and we say, yeah, you'll be fine. And it's okay. And we know we're doing this for a good purpose, but it can get pretty difficult for a lot of people, and we're on that roller coaster with them. And so what happens to us? So there is actually a substantial body of research around this topic. And although it's often scattered across different terms and specialties, rather than framed specifically as what happens psychologically to oral surgeons who witness pain every day, it's kind of piecemealed and you have to look with various terms. And so you'll find this in the literature on PubMed and wherever else through terms such as compassion fatigue, secondary traumatic stress, vicarious trauma, burnout, moral injury, emotional numbing, depersonalization, learned detachment, and what is sometimes called second victim syndrome. These ideas have been studied in trauma surgery, emergency medicine, oncology, ICU medicine, palliative care, anesthesiology, military medicine, so many types of surgery, pediatric surgery, transplant surgery, as well as OMFS. The big picture is this: repeated exposure to human suffering changes clinicians psychologically, emotionally, behaviorally, rationally, and even you could say spiritually over time. One of the most important findings in this area is that surgeons often develop emotional distancing in order to function. And to be clear, that's not always bad. There's many good, I guess you could say, beneficial outcomes or results as we do this emotional distancing. So if a surgeon is fully absorbed in every patient's suffering at a deep emotional level, we can become overwhelmed very quickly. Medicine trains us to compartmentalize, suppress emotional reactions, cognitively reframe suffering, prioritize performance, and detach just enough to maintain technical excellence. In the short term, that helps us do our jobs well, but over time, the same adaptation can turn into something less helpful. It can often become emotional blunting, cynicism, reduced empathy, depersonalization, difficulty connecting emotionally at home, loss of meaning and kind of purpose in someone's life. It can result in irritability just generally, and that can manifest in all aspects of our life. There can be emotional exhaustion. There can be difficulty feeling joy, hypervigilance, avoidance is a tendency that often manifests from in surgeons' marriages, and relationships with friends, kids, etc. Even shame surrounding complications. What makes this especially dangerous is that it often develops slowly, quietly, subtly, and under the label of quote unquote professionalism. One of the best known concepts here is compassion fatigue. This is often described as the cost of caring. It happens when continual exposure to suffering gradually reduces a clinician's emotional reserves. Symptoms can include emotional exhaustion, reduced empathy, irritability toward patients, seeing patients as tasks or problems, difficulty caring deeply, dread before clinical procedures or surgeries, and oftentimes withdrawal from relationships. Interestingly, compassion fatigue often affects the most caring physicians first because they're the ones who invest most deeply in their patients. Maybe a brief story that may or may not relate. I feel like it does, but um, you know, I personally I don't think I've ever been the most caring person. I'm sure I could have used um to be a much more caring, like expressive person, I would say. But I felt like I was maybe average, the average male in the United States. I don't even know how you determine that. But after residency, I certainly felt like some compassion fatigue and like a lot of these things that we're talking about, kind of like irritability, depersonalization type stuff, and just avoidance in general. And a couple of years after my residency, my mother-in-law passed away, and I attribute some of my reaction to that just to the effects of work. And I was incredibly um, just, I mean, I cared and it bothered me, and I was sad for my wife especially. But also, I was just kind of numb, I guess, to it, and kind of like death just seemed like another thing. And she had been sick, and it was kind of, fairly sudden. And I was very insensitive and uncaring and not very expressive to my wife. And that was a hard thing that we went through because of my reaction. I think a lot of that had to do with some of these things that had been kind of gradually happening to me as a person through my job. It took years for me to see that and to get through that and to kind of apologize and make things right with my wife because of that experience we had. Another important concept is secondary traumatic stress. This is essentially trauma acquired indirectly through repeated exposure to other people's trauma and suffering. Surgeons can develop symptoms that resemble PTSD, such as intrusive thoughts, replaying complications, even nightmares. I'm kind of, I don't know if we want to call it hypochondriac or avoidance type things, anxiety before similar procedures. You can get a very exaggerated type of responsibility, especially for, I think, most surgeons who um, take the brunt of the problems and say it's my fault. Oftentimes, just the pain of all that can result eventually into the stage of just emotional numbing. So, this tends to be especially common after kind of larger airway emergencies, catastrophic bleeding, nerve injuries, unexpected deaths, pediatric complications, anesthesia complications, litigation, or angry patients and families who kind of can oftentimes even just insult the surgeon's character and kind of go beyond just you didn't do the surgery right. This can be very tough, secondary traumatic stress. I experienced this early on in my career. I had an event kind of that I was indirectly involved in, where there was a pediatric anesthesia emergency and a young very young patient, suffered some very long-term, um, life-changing things due to a hypoxic event that causes brain damage. And for me, it definitely caused a lot of these things. There was, um, just replaying that complication over and over. Maybe I had some nightmares or at least very like dark dreams, thoughts, feelings about it, anxieties. I never saw counselor or anything. I just kind of got through it. But being part of that emergency and seeing some of the complications were hard. Were very hard. And what is striking is that a surgeon may look completely composed on the outside, but can oftentimes internally be replaying these events for years. And these events can have a very deep kind of subconscious alteration to someone and cause a deep anxiety, a fear, a lack of self-trust, maybe if things go wrong and you're the main one responsible, things like that, which can kind of bleed into your life. This goes hand in hand or is very similar to what's called second victim syndrome. So this concept is especially important. The patient who has a complication is the first victim, and then the clinician can often become the second victim. That term matters because it acknowledges the moral and emotional impact of adverse events on the surgeon. Just mentioning this, I think that can stir up a lot of thoughts and feelings. Certainly, if you said this to a patient, right? If a patient had a severe complication and I don't know if any surgeon would ever say, gosh, that I'm also a victim in this. The patient, of course, would throw it back in your face probably and say, that, I was the victim here. And I think that's what we focus on is the patient is the victim because it's such a tough thing for the patient. Oftentimes we can't even utter the words that we were some type of victim as well. The complication was our fault if it was um, an accident, if it was something that was negligence, whatever the cause was, us just being along for the ride and seeing this patient suffer, oftentimes due to some influence we had on the patient, can cause us to become a victim that suffers because of it. Research shows that surgeons involved in serious complications experience guilt, shame, depression, insomnia, sometimes self-doubt, and oftentimes that can move into isolation, and then in worst case scenarios, substance abuse, suicidal ideation, and even career withdrawal and extreme burnout where someone can't go on with their career. That I think happens and is happening more and more, or at least we're hearing more and more about that. Just a quick story. Again, early on in my career, I had a patient who um, was a younger patient in their 20s and had a growth inside of their buccal mucosa, did a biopsy and inadvertently damaged or kind of cut part of the Stenson's duct, and it resulted in a sialocele swelling of the parotid gland, multiple days in the hospital, lots of pain, lots of suffering. It's hard for me to explain like how much suffering it caused for me as well. Of course, the patient had more suffering, but I mean, it was almost like this like mental fire in my mind that just wouldn't go out. It was like an unextinguishable fire that just burned me over and over. I thought about this for weeks on end. I couldn't sleep. I mean, I had to call my friends from residency that were more experienced, attendings, and say, "Hey, this was what happened." Almost just to have like a therapy session and say, and help me make it through this because this is very hard. I feel so guilty and shameful and like responsible for what I did. I didn't intend for this to happen, but I just felt so responsible for this girl's suffering. And it was very, very tough. Many surgeons never fully process major complications because the surgical culture often rewards stoicism and silence. One of the most sobering realities in literature is that surgeons may remember complications from decades earlier with vivid emotional detail, just like I'm remembering this now. These things can really get ingrained in your mind. And there's just a part of it, I think, that is a subconscious um, effect that can sometimes have negative effects on you as a person and like kind of your personality. I don't know how to say it other than your spirit type of a thing. Other thing that we mentioned, or kind of a sequelae of seeing pain and suffering in your patients, is what we call depersonalization. Depersonalization is one of the classic burnout domains. It refers to emotional distancing from patients and viewing them less as people and more as tasks, problems, or pathology. It can look like referring to patients primarily by their diagnosis, becoming emotionally disengaged, becoming cynical, losing curiosity about patients' lives, becoming impatient with emotional needs, or becoming numb to suffering. I think a lot of us probably learned some bad habits in residency in this regard. I mean, I remember very early on in residency just kind of getting used to the fact that we named patients by their pathology. I remember we'd say, okay, um, that what's going on with that ameloblastoma patient, or are we going to take that squame 4 or that stage 4 squame patient of the mandible to the OR this week? Or have we done follow up on that myxoma of the right maxilla? Just and kind of referring to the patients more of just like the pathology. I think that subconsciously we're doing this to kind of depersonalize, distance ourselves, because when you give them a name and you call them, Eric Smith, or it just, all of those things, when you identify them more personally, connects you more to the patient. And when they suffer, if there's more of a personal connection, we suffer. And so I think we don't intentionally say, okay, let's all do this so that we protect ourselves. But I think it just kind of happens in this setting of frequent suffering, pain, and issues, as we kind of default to things that can self-protect. Um, but can potentially cause trouble later on. And so depersonalization is kind of like a protective mechanism, and it doesn't necessarily mean a surgeon is uncaring. It often means the person is trying to survive this experience, right, of dealing with pain and trauma and suffering. But I think step one is being aware that we're doing this and that it can potentially have negative effects on the way we view people and ultimately ourselves. So I'm just kind of going through these things first and describing what they are before maybe offering some potential solutions here. One of the last ones I wanted to talk about is called moral injury. Moral injury is another major topic in physician wellness and research lately. So this happens when physicians repeatedly participate in systems or situations that conflict with their deeper values. So for surgeons, that may look like feeling unable to provide ideal care, being under productivity pressure, dealing with insurance denials, having complications despite best efforts, feeling responsible for unavoidable suffering, operating while emotionally depleted. We've all experienced that in residency, being tired, overworked, but still, due to the system that's set up, having, or at least feeling like we have no choice but to just continue to treat patients, even though we're depleted, we're exhausted. Oftentimes, we feel like we're just in a kind of a broken system. And I've been there for sure. I've worked in many types of settings and systems. I've, been an associate of a practice. I've owned my own practice. I've worked in a DSO, multiple DSOs, and I've been in many situations where I felt kind of overworked. I felt like I had very little control over the type of equipment I used, the amount of time I spent with patients, and I felt like I was using like ineffective equipment that was cheap, and that I was seeing too many patients per hour, and that um, basically it was just I was in a system that was kind of broken and not working well, and it kind of just hurt my soul, right, to treat patients in that system. And that's when you start experiencing moral injury, because you get to a point oftentimes where you kind of throw up your hands. And I know this happens with like ER physicians, with all sorts of doctors that are working especially in hospitals or in kind of like big clinic settings, where they have very little say over the equipment they use, the hours they have, the amount of patients they see. And you kind of throw your hands up, and oftentimes you become cynical, and there's some existential exhaustion, there's loss of identity, and there's ultimately a kind of like spiritual distress because you're trying to do your best. You care about your patients, you want what's best for them, but you can't give that to them because of the system that you're inside of. You're kind of trapped. So it's one of the hardest parts of medicine because the surgeon is often not just dealing with technical difficulty, they're dealing with the moral weight of what's happening and seeing patients oftentimes suffering because the system isn't working properly. Our hands maybe are tied, or maybe they're not, or maybe we're unsure if our hands are tied or what we can do, and it can cause that moral injury. That's that one. There are a few recurring long-term changes that show up again and again when we're experiencing many of these things. One is hyper responsibility. A lot of surgeons begin carrying exaggerated responsibility for outcomes. We can often lead, or these things can often lead to chronic anxiety, perfectionism, inability to relax, compulsive checking, difficulty delegating, and sometimes catastrophizing. Some surgeons can become psychologically kind of on call even when they're at home, and oftentimes our minds never really turn off. That all falls under the category of hyper responsibility. Another one is this emotional compartmentalization at home. So, another common pattern is that the emotional distancing that helps in surgery begins to show up at home. Surgeons may notice reduced emotional availability, trouble discussing their feelings, irritability, like we talked about, what's called emotional flattening, or just kind of inability to really express and feel emotions, withdrawal, difficulty transitioning from work to home. Many spouses in the literature describe surgeons as physically present but emotionally absent. I mean, I know my wife has said that over the years, especially during residency and during the first few years of practice. I've heard many spouses say that. I think it's a common knowledge that the divorce rate is higher during residency, and um, I don't know the exact statistics, but probably higher in general for surgeons due to this um, kind of sequelae of shutting down emotionally and just kind of becoming more emotionally flat, impatient, and irritable um, because of the frequent pain and suffering we're witnessing. That just bleeds into our personal relationships at home. And then there can be altered relationships with suffering. So repeated exposure changes how clinicians interpret suffering. So for some, the negative path develops and they go through numbness, cynicism, emotional avoidance, minimization of pain, and a sense that everyone kind of just like everyone suffers, it is what it is. We all hear that phrase 1,000 times. And we almost kind of just dismiss the suffering. I don't know if you've ever been even just like a post-op with like a dry socket patient, right? And they're like crying, they're just going on and on, right? About how horrible the last few days are. And we can sometimes find ourselves just sitting there kind of going, okay, yada, yada. And it's almost like they're like the patient is like the teacher from Charlie Brown. It's like, want, 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 want. And we're like, okay, man, just cut to the chase. I know you're in pain. Let me irrigate this out, get the debris out, and put the dry socket paste in the gel foam or whatever it is you do. And that is like self-protection. We're kind of like, if we just sit there and really open ourselves up to the pain and suffering, and sometimes I think we're very scared and worried, what would that do to me if I did that? Would it hurt me as a person? And so I'm not going to do that. I'm just going to kind of sit here and be numb to whatever they're saying and say, okay, sure, yeah, whatever, kind of dismiss it all. And I know it's like, and the patients often can take this as like, man, that guy is really uncaring, or that gal just, she doesn't give a crap about me. But I don't think these patients see and appreciate, right, when this is going on for us as the provider, year in, day in, day out, year in, year out, to be exposed to this kind of suffering is a very protective, common thing we're doing. It's not that we don't like the patient, that we hate the patient. We don't think the patient's a stupid idiot. It's that we are protecting our own kind of mental whatever you want to call it, soul from being exposed to another person's pain and suffering. So that's just something I think is very common with surgeons. And then this begs the question of why is this so hard to talk about, or why do surgeons not talk about this process? This is definitely a kind of under the rug type of a thing that we try to avoid talking about. Big reason this conversation is so important is that the surgical culture often discourages us from really delving into this stuff. Historically, and I think all of us would agree, our residencies kind of affirmed that surgery and our attendings and everyone else, the whole system of training and growing a surgeon values toughness, emotional control, decisiveness, resilience, performance, certainty, you know, and like rule number 148 in the surgeon's code is that they must have their tear ducts surgically removed. I'm just making that up, but I once heard an assistant say that. She's like, man, I feel like that's part of the surgeon's code is you have to have your surgery. Sorry, I'm messing that up. Tear ducts surgically removed. Many surgeons fear appearing weak. We fear losing credibility, being judged. We feel like that could harm our reputation if we were to say, "Hey, man, this is kind of making me anxious, and I'm really feeling shame here and guilt, and like this is hard. I feel very sad. What happened is like really affecting me. This complication or this issue with this patient is like super hard for me to deal with." We feel like we're often burdening others, that maybe we minimize our own problems and say we have no right to say that this is bothering us when the patient themselves is the main one suffering. Because of all these things, suffering becomes private. And when suffering becomes private and untalked about and just kind of something that happens in isolation, that can kind of breed stress, anxiety, and problems. And it can amplify silence and isolation, and not talking about things can amplify the pain that we feel inside of us. So I think oral maxillofacial surgery and oral maxillofacial surgeons are uniquely positioned for this conversation. Oral surgeons perform painful procedures every day on people, and I think we can often create anxiety before treatment in our patients. I think most of our patients probably come in with anxiety and they're worried, and with good reason. They're expecting pain, and a lot of them will leave the office with more pain, or at least shortly after the numbing wears off. And we manage postoperative pain continually. We're seeing these patients in pain. We see trauma patients that are in pain. We see sometimes complications that affect someone's identity, their appearance, their function. We work at a very high procedural volume. We do many procedures, per day or per hour, and we're exposed to many different types of patients in pain and in stress and anxiety. And we can often have long-term patient relationships. We frequently deal with addiction and pain medication type complexities. And then we balance all that with production pressure in an outpatient environment. There's that pressure and that stress to continue to do procedures and make money, and quicker the better type of thing. Unlike some specialties where the major traumatic event is more episodic, I think OMS docs can involve a constant micro exposure to suffering throughout the day, and that can create a unique psychological burden, not necessarily massive isolated trauma, but a cumulative emotional erosion, so to speak. I think that's a very compelling and important topic for our field. I think this episode should leave us with some honest questions that we should be asking. One is, what emotional adaptations help surgeons survive training and just survive daily practice? How about, at what point does healthy detachment become unhealthy numbness? How do complications psychologically shape surgeons? Why do surgeons replay complications for years sometimes? What happens internally when we witness suffering every day? Why do some surgeons become cynical while others become compassionate? How can we become compassionate as opposed to, how can we become more compassionate and caring and less cynical and dismissive? How does surgical culture discourage emotional processing? What signs suggest compassion, fatigue, or secondary traumatic stress? What does healing look like for the healer? I think there are things we can do. Step one is recognizing that this is happening, that we are affected by I'll call it chronic exposure to acute suffering or acute pain. I think step one, recognize that it's happening. Step two, talk about it. Talk about it. I think probably a lot of us would start with colleagues, but I think that would and should also involve probably like a counselor of some type, someone who's hopefully experienced with doctors, with surgeons, and guiding them, through this process of burnout and suffering and pain. Hopefully, someone, and it's probably hard to find that person, but I think they exist. Kind of counselors, psychologists, people like that that are experienced. I've had people, even older surgeons, email me and say, "This podcast itself, just hearing someone talk about the experience of being an oral surgeon, dealing with these things daily, is just like a therapy for me, and has healed me in some ways just through this podcast or this discussion. And let's continue the discussion, and I'll call them. We'll have phone conversations. We'll do email things." And it's funny, the first time I heard that, it was like within the first 6 months of the podcast. I was kind of like, I didn't expect that. I was like, what? How is this therapy for people? But it just is when you hear other people going through the same thing. To say it out loud and talk about it is a way to heal. It's a step toward healing. And then I think step three would be to set kind of steps, goals, an action plan to try to change for the better, and if you've recognized you've become dismissive and kind of depersonalized your patients, what are some things that I'm going to do to personalize patients and to spend time and to open myself up and to listen better and to care more? And I think it's okay to still say, okay, there are certain things I'm going to do to still protect myself, but I probably can care some more and be more compassionate. And like with moral injury, what can I do to improve the system I'm in? Recognize if there has been moral injury happening, recognize what's wrong with your system, and talk with someone about that, and then try to have an action plan. What can I do to improve the setting and the situation? And maybe the solution's not an easy one. Maybe it's a hard solution. Maybe it's changing a job. Maybe it's talking to an employer or a boss or someone higher up that could potentially jeopardize, your how you're seen or your work, type of a thing. But I think doing some type of step toward trying to fix the problem also is healing, even if maybe whatever you're doing doesn't fix it or doesn't have an immediate response. I think just making an effort has a healing effect. So I'm sorry this is kind of a long episode. It's just me podcasting or kind of droning on in the podcast. But I hope this has spurred some discussion. I would really love for our guests and listeners here to do a follow-up text to me, an email, anything to reach out to say that this episode resonated with you and maybe how you've kind of come to combat some of these issues with being chronically exposed to suffering and pain. It affects all of us. And the longer you go on in your career, the more affected you are. I think we would all agree on that. So thank you to all of you for listening. And also thank you to all of you for putting yourself in the position to help others when it harms you in some way. And that in itself makes me a little emotional that you're all doing that, and someone's got to do it. And I appreciate all of you for doing that, for risking your own well-being to help others. And at the very least, that is a noble thing, and I appreciate you. So shoot me a text and email. Let me know your thoughts on this one, and I appreciate you listening. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com.
I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.